The next last topic is CMS final rule notification requirements for hospitals. And we have Jitin Asnaani, VP Strategic Partnerships at PatientPing. And what Jitin is going to do is provide an overview of the CMS e-notification conditions and participation that will be required per the CMS Interoperability and Patient Access Rule, including implications for both health systems and payers. And so, Jitin, you're going to take us home here?
Terrific. Happy to do so.
Thank you very much.
Excellent.
All you.
All right. Fantastic. I'm going to share my slides. Are we seeing them?
Yes. Perfect.
All right. Fantastic. Terrific. Thank you again to the team for inviting me over. Happy to share, the CMS rules and the accompanying ONC rules had so much content in them. Sometimes it's hard to catch up with all the different pieces, and certainly get explanation of all the different pieces and understand really how important they are to the overall kind of framework of regulation, as well as to each organization that now has to contend with these pieces. So I'm delighted to have an opportunity today to share one particular aspect, the e-notifications condition of participation. By way of introduction, really, for the audience. I'm Jitin Asnaani. I'm the head of partnerships here at PatientPing. PatientPing is an organization that has built a national real-time notifications network in support of care coordination nationwide. Previously, I led Commonwealth Health Alliance. I led that for 5 years until last December. Prior to that, I worked in product innovation at Athena Health, and really started my career in health IT, particularly at the Office of the National Coordinator for Health IT. So I was a 2-year government appointee back during the Obama administration, and previously an engineer, and then followed up to the dark side, by getting an MBA. So that's my history in a nutshell. Certainly spent a ton of time in the realm of standards, interoperability, and the use of data exchange towards business purposes. So that's what I'm happy to hear. Use that background to share this specific rule with everybody. My plan for the next 25 minutes or so is relatively straightforward. I want to just share the context and some interpretation around the CMS COP requirements, including what it is and what its tenets are. I'm going to very briefly use PatientPing as an example, since it's very close to home, obviously, to show how we're solving for those CMS COP requirements, to try to make it a little bit more concrete for those who want to understand how this part of the rule works. And then I'm going to actually lead it into implications. And the implications here for hospitals and health systems is actually, there's a number of them, and actually they're a little bit more obvious because they're spelled out in the rule. There are also implications for health plans, and I'm going to certainly spend a few minutes on that as well, because I do think it's important that the import of the rule is not lost. Given again that there's so much context around the set of rules that came out back in March, and of course, hopefully leave some time to answer questions here in real time, or if necessary, offline. So with that, I'm going to jump into it. Like I said, the bulk of my discussion here, what I'm going to share, is really around the first goal. So the ONC and CMS interoperability rules, as you recall, kind of plunked down in March on our collective desks. And in particular, the CMS interoperability and patient access final rule that we've spent a tremendous amount of time here today, discussing, had one section in it, substantial section, that was around the e-notifications condition of participation, here highlighted in the dark blue. That's specifically the piece of the overall rule set that I'm spending time on here today. As part of that rule, it's like any part of the rule, there's a fair bit of verbiage and discussion that goes into it. So I'm going to summarize really 2 big points, from the language of the rule that came up. First of all, this is a rule who has a compliance date of May 1st, 2021. Denise articulated the whole timeline of different compliance dates earlier today in her session, and this specific one is from May 1st, 2021. The crux of the rule, if I may use that word, is that hospitals must make a reasonable effort to send ADT notifications, admit, discharge, transfer notifications, to a variety of downstream provider organizations, post-acute providers, primary care practitioners, practice groups, and entities. If you just think of the buckets of primary care and post-acute, that encompasses the most of it. and for the purposes of treatment, care coordination, and or quality improvement activities. So that is the sort of the center point of the rule. And if you break that down a little bit, what it's saying is that the rule applies to hospitals across the spectrum. Three particular sets of hospitals can readily come to mind, but it actually applies to acute settings across the spectrum. So hospitals, psychiatric hospitals, critical access hospitals, typically those three are distinguished. Again, all are game and subject to the rule as it's written today. And so they're on the hook for sending real-time e-notifications. Who they're, on what events are they on the hook? Really, it's 5 events. On the inpatient side, it's admission, discharge, transfer. And in the emergency department, it's all about presentation and discharge. And who they're sending it to, as I mentioned earlier, is to establish PCPs, primary care practices groups, post-acute, and that entire care continuum from PCP to post-acute. And what's really interesting to hear is that it's not, for those of you who have kind of followed CMS and ONC rules of the last 10 years, the prevalence of including post-acute has certainly increased over the last 10 years. And this rule very squarely calls out post-acute sites. So we're talking about SNFs, home health, and so on. Also, where some previous rules have really talked about primary care or specialists, this one talks about both PCPs, not a surprise, but also primary care entities, which encompasses things like FQHCs and ACOs and the like, who have not necessarily been the subject of previous rulemaking, certainly when it came to things like meaningful use. So again, it's this rule is interesting in terms of its intent to enable real care coordination across the continuum of care where patients really go. The data itself called upon for this rule is actually not very deep data. It's a patient name, it's the treating practitioner's name, and the sending institution name. And it's really, again, meant to convey that an event has occurred to a patient, and it's meant to convey that in real time, so that downstream participants who are engaged in the care of the patient have an opportunity at that point in time to either take an action or prepare so that the patient can be treated and whose care can be well coordinated across the continuum. So that's what the rule really comes down to. In order to achieve the rule, hospitals and health systems are going to be accountable for really providing 2 types of functionality, as well as demonstrating that they have and have utilized these types of functionality, which I'll get to separately. The 2 types of functionality, roughly speaking, are the ability to send notifications for patients towards providers who the patient has identified. For example, at the point of care, for example, in getting admitted into a hospital and during the intake process, a check-in process, or when they're getting checked into the ED. So for that provider that the patient themselves has identified, the hospital and health system is on the hook and sending notifications to those providers who the patient identified. This is most typical and what most typically apply really in terms of who the downstream recipients are would be PCPs and it really is any patient identified practitioners, but PCPs and sometimes specialists are the most commonly identified. That's one set of capability that hospital health systems need to be able to have. If you think about kind of care coordination and how it works, largely across the U.S. healthcare system, a bulk of where data exchange happens or where care coordination happens is when the provider themselves request for the patient's information. And so the rule gives you allowance for that, where it's all about being able to respond to the requests of e-notifications on behalf of the patients to requesters such as post-acute entities and primary care groups. So everything from SNFs, home health, FQHCs, HCOs, PCPs, and the like. The health system in that situation needs to be able to send notifications on the requester's attributed patients. And there are a number of ways of describing attributed patients. Medicare uses attribution files, and other companies use rosters or registries and the like. But in those situations, being able to actually respond for notifications for those patients who have that attributed relationship to that provider. Again, Across the healthcare spectrum, this is not an uncommon exercise. So primary care groups, post-acute providers, ACOs, POs, SNFs, HHS, hospices, IPAs, all the like, are the likely recipients of e-notifications in this scenario. And again, the hospital and the health system is on the hook to be able to provide this functionality as in order to kind of meet the rule. Of course, providing the functionality is one aspect of it. Another aspect of it is actually demonstrating. And it's not just demonstrating, unlike, for example, meaningful use certification program, which was, instead of ONC rules, it's really around actually demonstrating that they have complied with this set of requirements and have performed reasonable effort in fulfilling the notifications requests, on behalf of, whether the patient or the requesting set of providers, eligible providers, I should say. So the implications for the provider, the hospital and health system in this case is, of course, is actually pretty important. You can imagine as part of the survey process, the hospital health system is going to have to deal with actually a fairly typical set of auditors who would we usually expect as CMS contractors who would come out and, CMS authorized auditors who will come out and review organizational structure, interview the head of medical records, actually look at to see if requests were fulfilled, get some sort of proof and confirmation that they were. And then, in the case that a hospital has not been found to actually have met the rule, then give them an opportunity to remedy that situation, or else be in a situation where their payments are at risk because they have not taken correct action within a period of time. Much of the specific auditing kind of steps is still TBD. So we're all kind of looking forward to seeing how auditors will actually perform, but this is not a new motion for CMS or for its auditors, and so this is a very typical example here. But one point I'll make over here is that this is the ability to, if we think about sort of the general arc of what we've talked about over the course of today, or for those of you who are tracking regulation over the course of particularly over the course of this last year and the last year and a half, there's a very clear trajectory towards more information sharing, right? Hopefully not a big revelation to anybody who's listening in on this. And it comes to two types of things. It's the ability to send data and a demonstration that you are. It also comes to an ability to demonstrate that you're not creating sort of discriminatory practices. In other words, when you're sharing data to a provider you like, who's in a particular situation, you're also sharing with other providers who are in a similar situation, regardless of whether your relationship as an organization to that entity. And so this notion that you have the right set of policies, procedures, and systems, and that you're executing on the rule, will be fully sort of come into play in the course of trying to demonstrate compliance to this rule. And that's a really important point to underscore, because it's not just the mechanics, it's also the policies and procedures that come along with it. So with that in mind, let me give you a relatively quick explanation of how PatientPing is helping our customers to solve that problem. Again, for those who don't know PatientPing really well, I have a single slide just to explain what we are. Somewhere our CEO is wondering, how did I distill the last 10 years of effort into like a single slide? But sorry, Jay, that's exactly what I did. So PatientPing is driving e-notifications experiences at scale nationwide. We have a nationwide network. We have 43 million patients, more than 135 million patient counters. In fact, all these stats are about 5 or 6 months old, so I really should update them. But certainly nationwide on almost 30 states where a variety of consuming organizations are utilizing our network through the suites of products and services and partners we have in order to drive care coordination. And like any network, we have a sort of ascending side and a receding side. In some networks, obviously, those are the same thing. In ours, they're subtly different. Senders tend to be hospitals, and we have more than 1,000 of those, and post-acute settings. And we have almost 6,000 of those. And receivers of these notifications are organizations who typically understand how to utilize that data to be able to engage in care coordination. So probably at the top of the list, or certainly near the top of that list, are the risk entities, particularly ACO, so at-risk entities, delegated entities of that nature, provider organization, others, physician practices, and some subset of the post-acute facilities as well, who are managing the care of that patients across the continuum. So that's what PatientPing has done. And again, these organizations on the right-hand side consume the data that's shared with organizations on the left-hand side. And of course, there's high degree of overlap there, but they consume that information through a set of different services and products we have at the point of care or at the point of coordination or at other parts of the continuum. And no surprise, we're working with some of the largest health systems, both in terms of acute and ambulatory health systems, as well as post-acute health systems across the US in enabling these interactions. The product we have is a solution called Route. Again, I'll try to be quick around it. I just created a single slide just to illustrate what it is, a solution that helps to guarantee COP compliance is on the hook to do. And then we'll get into implications. What does this mean for the hospitals, health systems, and particularly what does this mean for our health plans? And so again, it's these four capabilities, unsurprisingly related, indirectly related to the framework I set up up front. The first one is patient-identified provider notifications, and that's really what we do is we take in the information captured in the registration system and ensure that notifications are delivered to downstream providers to the best of our ability, to the best of the industry's ability, really, such that those providers are notified per the patient's desire. And they have the ability, of course, to opt out or unsubscribe, et cetera, because the rule certainly does give leeway for providers to be able to absolve themselves of getting notifications that they don't want. The second capability is the ability to capture those requests from provider organizations. And that's a huge deal because that's actually a process that requires the recipient of those requests, in other words, the hospital or health system, to be able to vet the requester and ensure that they have the right legal agreements in place so that clinical data can be exchanged safely, securely, appropriately, and then actually being able to manage those patient-provider attributions. And so we form all of that as a sort of a managed service, even for requesters who are not on the PatientPing network. We are one of the largest post-acute aggregators out there, but even if it's a requester who's not on our network or is a primary care organization that's not on our network, will fulfill the request on behalf of the hospital. And then finally, obviously, an audit trail that shares kind of everything we've done really back to the hospital and health system, including giving them the insight into who's requesting their data, which is a very useful tool for hospitals and health systems to really optimize around the relationships they have with the community. As sort of a bonus add-on we add in to the overall suite is the ability to manage ADT feeds from our service back to anyone else who the hospital wants to share ADTs with, just as sort of an added service that comes very naturally to it. So our solution over here is a fully outsourced set of technical capabilities and operations workflows such that the hospital kind of hands it to us. We ensure that they get compliant, we ensure that they have the data they need, but we also just ensure that any workflows that have to do with outside exchange are completely managed and not yet more burden on the thin resources in the typical IT staff of a hospital health system. And so we guarantee compliance. Okay, so that turned out being a little longer than I expected to be, but hopefully that captured and gave you a sense of what a COP solution looks like for, again, this really important part of the overall rule set. The implications for health systems and health plans is where I want to spend the last few minutes before we turn to questions. And for the health systems, some of this is probably very obvious given the nature of the rule and what I've shared about the rule so far. Identify and send e-notifications to all the eligible providers. Be able to meet the provider's notification needs, regardless of where those patients are asking you to send that data, or regardless where those requests are coming from. They could be nationwide. So it's really important that as a hospital or health system, you are focused on enabling that data exchange to happen, not just within your community, certainly not within just your own four walls, but wherever that patient may be getting care across the nation. manage these continuous patient-provider relationships, and then leverage that insight to be able to, the requirement is to be able to fulfill the requests. The sort of obvious next step as a hospital health system is to be able to use that information to be able to understand where do your patients get care, and how you can engage with those other entities across the continuum who are requesting data on their patients. So there's like all things information blocking and data and exchange interoperability. There is what work are you putting me on the hook for, and the corresponding strategic what can I gain out of this myself opportunity. And we're always going to encourage organizations to think about both sides of that. Certainly wearing my hat in sort of federal and state capacities, I always encourage organizations to look at these rules as an opportunity to really evolve their business towards the future. Then on top of that, of course, there are some nuts and bolts things. Ensure that you have appropriate data sharing rights, security, trust, policies, procedures, etc. Most of which we help with as PatientPing, but certainly regardless of the solution that a hospital takes, they have to ensure that they cover that, meet their survey requirements, and meet them by May 1st, 2021. For health plans, it's a little less obvious, but it's actually just probably as impactful, if not more in some cases. So plans are not directly eligible e-notifications receivers per this rule. At least in the final version, at this point in time, they are not. If I were to be a betting man, there's a great chance that some future rule version would have it, but certainly there's nothing being particularly articulated around peers directly themselves. But on the other hand, in this version of the rule, final rule, at-risk primary care entities like ACOs are very much eligible to be able to get notifications from hospitals and health systems. So, to the extent that these at-risk entities are certainly independent and working in conjunction with payers, there's a direct implication there. There's also the broader continuity care, right? There's a primary care, post-acute care, who are all important parts of ensuring that the patient gets appropriate care and most cost-effective care, and they're all eligible to participate. So this e-notifications rule really can enable a broader wraparound communities from the perspective of a health plan that allows members of the health plan to receive better coordinated, lower cost care across the continuum, an opportunity to impact follow-ups post-discharge, and opportunity to impact transitions across the continuum, including into primary care, into skilled nursing facilities, and even into the home. And again, these are just core parts of ensuring that we are in pursuit of the triple aim. And there's a really clear opportunity for plans to take advantage of the tailwinds created by this rule to be able to drive further along this, their initiatives to contain, to enable more effective care coordination. So for a plan, in terms of sort of direct implications, there's a potential to leverage the existing assets and relationships to further drive coordination of care in conjunction with these developments. One final thing I'll add in, again, I'm going to use, since we're in this business as well, I'm going to use ourselves as the as sort of the point of an organization that can help create the value here, even if it's generally applicable. But solving for CMS COP is, again, part checking the box on the rule and ensuring you're doing the right thing. It's also being able to leverage the opportunities it creates. So for hospitals and health systems, it's very clear, a product like PatientPing Route removes all the technical and operational burdens of just meeting the rule, including meeting it today in terms of implementation, as well as the ongoing need to support requests and send notifications and the like in order to fulfill these COP requirements. For health plans, as well as this hospitals, health systems, and really the entire continuum of care, again, the COP rule and PatientPing Route in particular, in the way it's kind of addressing the rule, creates opportunities for more efficient care in communities, nationwide. And that is a fundamental opportunity created when this data is allowed to become liquid as per the intent and push of this rule. So I'm very excited, just as a sort of an industry stakeholder who participates across different organizations across the industry, to see how this is going to help us with our this decades-long effort of trying to transform healthcare. If anybody has any more further questions, looks like we have a couple of minutes left, so I'm going to answer questions. But there are additional resources here that we've created that everybody is welcome to please go out and take a look at, as well as my information here. If anybody would like to reach out to me directly, I'm more than happy to engage on this topic.
Thanks so much. That was great. Another one of these that went by in a flash. So much content, and congrats on all the great work that you guys have done at PatientPing. How about this one? What do you think about this? Curious about health plans. How are they planning to outreach to members for this kind of service?
So I think there are a couple of means health plans have for enabling, for really leveraging this rule towards a better benefit, right? So in one case, the direct relationships that health plans have with hospitals and health systems, whether they're in partnership or whether they're in ownership kind of situations, the opportunity to ensure that they're meeting this rule, not just to, there is a tendency across rules, in CMS and ONC rules, to be able to evaluate whether we should do the least possible to check the box, to leave it up to some degree of chance, or to ensure that we've actually done what we can to build the value that CMS is very clearly trying to articulate in the host of preamble they put in this rule. And so there's its direct ability to work with those health systems, health systems and provider organizations to actually utilize and implement this rule in a way that is valuable to the goals of that entire community where the health plan operates. There's also the ability for health plans. Health plans do engage with organizations like PatientPing to enable care coordination and other types of use cases. And there's an opportunity to directly engage with PatientPing and others who are benefiting from the tailwind here that's being created to, again, just enable care coordination. Like that's our mission and purpose. That's what we're driving towards. And there are others in the space who are also trying to enable better care coordination and certainly and sort of reduce the overall kind of cost and complexity of care. And that's where there's an opportunity for plans to directly engage and not just be beholden to the downstream effects.
Yeah, no, that's good. Here's another one, a little bit from one of our guests. Some data such as drugs being taken can indicate HIV. What are you suggesting plans should do? Just exclude that data, or does the member have ability to say, okay, to see all data?
So in the narrow context of this rule, there's really only 3 data elements being shared: the patient's name, the location of care, and the treating provider. So there's not a ton of information being shared in the context of this rule. That being said, it is no doubt that other types of data will get shared in the context of rule. Like today, the average ADT event notification actually has other information as well, and not just those 3 elements. I think here, CMS was aiming for something that could be broadly applicable, virtually any registration system. It's not precisely true, but it is broadly true, can meet these requirements. That does mean that there's a downstream ability for organizations to be able to leverage that data when shared for purposes that are appropriate and under the guidance of HIPAA. What I actually think will happen, Joe, is that oftentimes they will get that sort of data and they will utilize other complementary rule mechanisms to be able to, if they got the real-time notification, then use other complementary mechanisms, some of which we're enabling ourselves through PatientPing, but that are going to exist out there, like TEFCA, to be able to get more data on the patient that matters to that particular patient's scenario. So I do think there's a nice kind of fabric of rules coming together here that allow the data to always be available. And in this case, this specific rule just ensures that you know when an event is happening. Create the moment where you can take an action, and whether it has the data itself or gives you other avenues to go get the data, there's an opportunity to take appropriate follow-on actions.